Hello, and welcome to the Duke Cardiology Conference. I'm Sunil Rao, Associate Professor of Medicine at Duke University Medical Center. Today's program is titled, A Look into the Future of Antiplatelet Therapy, and our distinguished guest is Bob Harrington, the Richard Sean Stack Distinguished Professor and Director of the Duke Clinical Research Institute here in Durham, North Carolina. Bob, thanks for joining us.
Sunil, thanks for having me.
So, Bob, antiplatelet therapy obviously has been on everybody's mind over the past 5 years, and there's been just this incredible amount of information coming up. Tell us a little bit about what we can look forward to, and then we'll talk about a little bit about what we've heard so far in the last 5 years.
So, clearly an important topic, clearly something that's very timely. At the recent American College of Cardiology meetings, this remains an important thing for people to think about. And in large part, I think it's been something that's on the forefront of people's minds because of the success that we've seen with antiplatelet therapy. I would summarize it in the following way, Sunil. First off, platelets matter. That we now have an enormous body of high-quality evidence, meaning well-designed, well-carried-out randomized clinical trials that show us that antiplatelet therapy, aspirin, 2B3A inhibitors, ADP inhibitors, that they matter, that they reduce clinical outcomes amongst important groups of patients. The second point is that, relating back to the first, is that multiple mechanisms matter. So we know that the aspirin pathway, the ADP pathway, the 2B3A pathway, those are important mechanisms of action in terms of platelet function, and inhibiting them seems to be important. It's been interesting that there's been some key lessons of late that I would summarize somewhere like the following: that more intense ADP blockade appears to be better than less, that most of these therapies have an effect on reducing MI, although the recent ticagrelor experience suggests to us that maybe reducing mortality can happen, that something that's near and dear to your heart and that you've talked and written a lot about, there is this balance of efficacy and safety, particularly bleeding, which I think is one of the great challenges moving forward. And maybe in light of the gravitas results, we have the first inkling that, yes, the personalized approach is attractive, but it may not be so easy to get there.
Yeah, and that's what I want to touch on after we talk about what we can look forward to is, where are we going to go with personalized therapy, or are we still stuck with a one-size-fits-all?
I think I'm going to try to weave some of that in. So on the slide that you see here, Sunil, is why the platelets might matter and why developing antithrombotic therapy appears to be an important thing to do from a global health perspective. This is just looking at the global cardiovascular burden of disease and just pointing out that the cardiovascular disease remains a global epidemic. It is going to grow in the countries with emerging economies. And one of the things to think about from a social perspective is that as we see the growth of cardiovascular disease in these other countries, we also see a bit of a shifting of the demographics of cardiovascular disease, whereas in our country, it largely is a disease of the late middle age to elderly. In other countries, we're starting to see mortality, cardiovascular mortality, at younger ages, which obviously has implications for how those economies, develop, what is the burden of losing people in the prime of their life, et cetera. So I think there's a lot of important social things in addition to the medical questions. So let's turn our attention to the medical question. I made the point that that multiple mechanisms of action seem to matter in inhibiting platelets, and in fact, over the course of the last decade plus, we have learned an enormous amount about how platelets work and the various receptors, the signaling pathways, ultimately, with the expression of the 2B3A receptor. So there's multiple ways to attack the problem. And it raises the question of, is there a preferred approach? Is it combination therapy? Is one way worse than another? And I don't think we know that yet. It also raises the question that we were starting down that path of the personalized therapy, is might one way be better for some people? And I don't think we know that yet. But I think that's clearly one of the issues in the future. So let's talk about some of the drugs, some of the new things we're going to be seeing. Nice overview presented in the JCC last year from the group from Gilles Monlesco's group in France, looking at an overview of all the new P2Y12 inhibitors versus Clopidogrel in percutaneous intervention. And in that particular systematic overview, what do they show us? That in aggregate, the new P2Y12 inhibitors more intense blockade, more sustainable, more predictable blockade, appears to be better than clopidogrel, but it comes at a cost, and it comes at a cost of bleeding. And so how to balance that, I think, is going to be critical. We now have some interesting information about an old class of drugs. So another systematic overview recently published this year, also in the JCC, looks at 2B3 inhibitors during PCI in the setting of using stents and thienopyridines. One of the big questions with 2B3 inhibitors, as you know, is does it really add anything to contemporary therapy? In the systematic overview, it appears that it does. But again, at a cost. Yeah. So 2B3 inhibitors clearly are beneficial, but at a cost, and that cost is more bleeding. When we think about the future, Sunil, one of the things that I think is important for all of us to think about, including the listening audience, is how do you think about developing new antiplatelet therapies in the context of the kind of patients that are going to be treated with the drugs? And so on the slide here, what you see is some demographic information that you're familiar with from the ACTION registry, which is U.S.-based, but includes the spectrum of ACS patients, from non-ST elevation MI patients up to ST elevation MI patients. And it offers a nice contemporary snapshot into who are these patients. And that's important because we have to start thinking about, okay, if we're going to develop new antiplatelet agents, who's going to be treated with them? And are there things about those patients that we ought to think about, whether we're thinking about efficacy or are we thinking about bleeding? So I think there's some really important information on this slide. A couple of comments I'll make. The non-ST elevation patients, these are elderly patients. The median age, here it's the mean, but the median is about the same. It's the late 60s. But that's not what's so striking to me. What's striking is that when you look at the interquartile range on age, the upper quartile now starts getting to the late 70s, early 80s. And what is it, 5-6% of the patients with non-ST elevation syndromes in the U.S. are over the age of 90. So now you've got to think about, the burden of aging with all the comorbidities of chronic kidney disease, other associated illnesses. And if you just look at the non-ST elevation patients, you see high prevalence of diabetes, a lot of prior infarct, heart failure is common. What we don't have listed up here is chronic kidney disease, which is also common. So I think you start to think, well, if we're going to treat that spectrum of ACS patients, remember they're not all the same, and this gets back to the personalized approach again. Might we need to think about people differently? Terrific overview last year in the JCC by our friends down in Jacksonville who have looked specifically at some of the issues of antithrombotic therapy in the elderly. And what they do in this article is they point out some of the issues that might affect drug metabolism, how one responds to therapies, particularly in elderly population. And if you're going to treat 6% of your patients over the age of 90, you've got to think about these things. So you've got to think about the future of antiplatelet therapy in the context of the patients that we're going to treat.
Bob, when it comes to elderly patients, or what I no longer refer to as elderly, but older patients as my own years go by, is it more of a safety issue? Is the efficacy issue still the same, or are we challenged by greater platelet reactivity, different pathways in the older patients?
It's a great question. I don't think we know that. I think a lot of the analyses looking at this group of patients have focused on the safety. Mm-hmm. That you know this. If you look at the three greatest predictors of bleeding risk in every data set we have, what are they? It's age, gender, and body size. Right. They come out over and over again with various degrees of weight attributed to them, but age is always number one. Yeah. And so when we talk about risk, we're usually focusing on the safety risk and not the efficacy risk. I think that we haven't well worked that out. We don't know, for example, if as that bleeding risk raises, are we attenuating some of the efficacy?
Right, because age is also a predictor of recurrent ischemic events.
Right, and I don't think we know what that balance is. It's been interesting. There's been granted pediatric exclusivity in drug development. Right. A number of us are beginning to have conversations now around, should we have geriatric exclusivity? Mm-hmm. In other words, should people be rewarded for doing some focused clinical investigation in what I'll call the advanced elderly, over the age of 75 or 80, where a large portion of our patients are currently residing.
Do we have information about why these patients aren't getting into trials? Is it because they don't want to be, or is it just because we're not approaching them?
I think it's a combination of things. First off, on average, let's take the acute coronary syndrome trials. About 15% of the patients in these trials are above the age of 75. So we have some information, and particularly when you look at an aggregate. But if the median age is 70, we could do a bit better, right? And you know this, that while the ACTION registry says that the median age of the patients we're treating is almost 70, in the clinical trials, they're enrolled at like a median age of 62 to 64. So it's clearly a difference. So I think, number one, they tend to have a lot of comorbidities, which are exclusion criteria. You know, renal dysfunction, hepatic disorders, concomitant things like cancer. And I think there's also a bias on the part of both patients and investigators saying, oh, you know, that's a frail little old person. I'm not sure I want to put them in the trial. You know, my retort would be, that's exactly who we want to put in the trial. That's who we have to figure out if this therapy is going to work, because that's who we're going to treat.
And they're clearly at the highest risk.
And they're clearly at the highest risk. So we've got to do a better job of figuring that out. I think that older patients, you know, I've not seen any literature on this. I suspect there is some. But the anecdotal experience, I mean, you've consented a lot of patients. I don't think that there's a difference in approaching an older patient for participation in a study versus a younger patient.
Yeah, and I think my hypothesis would be is that probably the bias on the part of the physician is probably stronger. We just probably don't approach them as often.
Yeah, now, an area where there's probably a need for some good quantitative research.
Absolutely.
Well, let me keep moving here. The other issue in terms of personalization is the whole issue of diabetes. I said that, you know, 30-40% of these patients have diabetes. And there's been a whole series of papers written that diabetes, the platelets are, you know, hotter, they're more reactive, and maybe diabetes represents a subset of patients who gain preferential benefit from more intense antiplatelet therapy. I think that's a hypothesis. A lot of people like to say that it's proven. I don't think it's proven. I think we have some data going in different directions, but I think it's a reasonable hypothesis, and there is a biological underpinning that makes some sense. So I would like to see some focused clinical trials in diabetes with antiplatelet agent. Well, let's talk about some of the drugs. I don't need to spend a lot of time on this one because this is your work with the Linacryl. But for the audience, I mean, this is a new, as you know, a reversible and competitive P2Y12 inhibitor. It's the only one we now have available both in an IV and oral form that's undergoing clinical investigation. It's a very interesting drug, and with your leadership, with a number of other folks, including Paul Goebel, who's done a lot of the sort of early work, I think we see a couple of things with the Linacryl. Clearly, it inhibits platelets in a mechanism that you would expect being a P2Y12 inhibitor. Secondly, it appears that we can predict its response based on some, you know, PK/PD understandings. And thirdly, it has been exposed to the rigors of some early clinical trials to gain some sense of whether or not it might be an improvement on Clopidogrel. So here's data from your work, the Innovate PCI trial that you presented last year at the ESC meetings, and just pointing out that you can get the advantage of the early IV bolus. You can then transition patients to the oral form of the medication and get both immediate and sustained platelet inhibition.
And I know that transition point was where a lot of people were focused on, given some previous experiences with intravenous.
Exactly. So a lot of the issues that we faced with Cangrelor, and I think we're going to talk about Cangrelor, that transition from Cangrelor to Clopidogrel has proven to be something that you really need to think about, and we need to study. We needed to study pretty intensely. Here, you don't have that issue. You're going from same drug to same drug, as opposed to Cangrelor, you're going from one drug to another drug. I think it's a little bit of a different issue, and as you know, these data are in press. That brings us to Cangrelor. Cangrelor is a really interesting drug because it is an ultra-short-acting ADP receptor antagonist. It also is rapidly reversible. So it's got a half-life of about 3 or 4 minutes. It's rapidly reversible. So you might say, great drug to use in the acute care setting. Boom, you turn it on, people get an immediate effect. You turn it off, it goes away. And as you know, we, along with Deepak Bhatt, led a couple of very large clinical trials that were published back in 2009 now, looking at the effects of Cangrelor in 2 different but complementary groups of patients undergoing PCI, with different clopidogrel strategies as the comparator. Clopidogrel up front versus a commonly used strategy of clopidogrel at the end of the procedure. Yeah. Did both of these trials. The DSMB recommended we stop both trials because of futility, meaning that cangrelor was not going to meet its original hypothesis of being superior to the comparator. And we presented both of these a couple years ago and published it. But after we presented and published the preliminary data, meaning the primary endpoint data, we began to tease through the rest of the data pretty carefully. And what we found, and which we're beginning to report now in the literature, is that when you look at some of the harder events, Q-wave infarction, stent thrombosis, there's a suggestion that cangrelor, in fact, did exert a therapeutic effect that we might have missed, mixed in with all the other myocardial infarctions. And that has formed the basis of a hypothesis. And I like to use this slide because I make the comment that we now have cangrelor rising from the ashes, as the Phoenix did. And we're doing a large clinical trial called Champion Phoenix because, to the sponsor's credit and to the investigators' credit, people have said, we think there's something there. But we also accept that it's a hypothesis. And so now we have to test it.
I find this pretty remarkable, actually, because oftentimes, especially in the phase 3 setting, if the trial is neutral, that's the last you hear about things. And I wanted to get to this a little bit later, but I think this is a perfect segue, is your thoughts on revisiting therapies, whether they were, popular at one era or not, as background therapy changes, and something like Phoenix where, you tease through these very large, I'm sure very expensive trials, and you say, geez, there still is some potential here. I mean, that's a very unusual thing to have happen in the drug world.
When we got the call from the DSMB that said we're recommending you stop for futility, I mean, Deepak and I were surprised, to say the least.
Yeah, I bet.
We then began to look at the data, and things start to emerge. And I'll give a lot of credit to our executive committee of academics who were pouring through the data, the sponsor who was pouring through the data, saying, why did we miss this? We have pretty good evidence now from Triton that when you give more potent ADP blockade than clopidogrel, you get an effect in PCI patients. Why did we not get it here? Was it this interference with clopidogrel as you transitioned? Was it that there was something else about the drug? Was it that the 2-hour infusion was just not enough? What was the issue? And one of the big things we found is that this was a population where it was really hard to adjudicate the events. We tried to streamline it. We didn't collect a lot of CKMB. And I think we may, again, hypothesis, we may have a lot of events which may not be of the same significance as a Q-wave event, as a stent thrombosis event. And I think, to the sponsor's credit, they want to test it. I'd like to say about cangrelor, it's a drug I think works, but I'm not sure we can prove it. And, think about it. You're trying to prove that you give something for 2 hours, and that makes a difference. I think that's a high hurdle. FDA has been very supportive of doing another trial because the FDA sees that there's a need for a short-acting reversible ADP blocker.
Yeah, certainly in the clinical world, we would see a lot of utility.
Yeah, I thought Dave Faxon wrote a nice editorial when it didn't accompany the main papers, but it appeared in one of the interventional journals where he said, look, this is a therapy we'd like to have. But I understand that there could be some difficulty developing this. So cangrelor is being pursued in other indications where, again, the clinical imperative might really call for a need here. And you know this, that what do you do when patients are going to go to CABG who are on clopidogrel? Well, you stop their clopidogrel.
Right. You got to wait 5 days?
What might happen to them? We know they have bad coronary disease. They just had an acute coronary syndrome. Maybe that 5 days of stoppage isn't so good. And a lot of people have talked about, wouldn't you like to have something you could bridge these patients with? There's a whole lot about, broken hips, gallbladders out, people on clopidogrel, where having a bridging strategy might be helpful. I mean, we bridge them now with things that make no sense. Enoxaparin, that makes no sense if you're on antiplatelet therapy and you're bridging somebody. 2B3 inhibitors, does that make sense? Maybe a little more than enoxaparin, but does it really make sense? Replacing it with another ADP blocker might be a good idea. So there's a trial going on that we're not involved with called Bridge that we hope will provide some answers later this year about a bridging strategy. Okay, we've talked about ADP. Let's move to some of the other drugs. The thrombin receptor antagonists. Terrific overview in the European Heart Journal last year on the concept of the thrombin receptor antagonist. This is proved to be an elusive target because, as you know, the way that thrombin interacts with the receptor is a very interesting one. It's a tethered ligand approach.
Right. And
so finding therapies that can interfere with that has proven to be quite difficult. But a couple of companies have, and we've been working. This particular slide just shows you the different thrombin, the PAR receptors as they're called, what their primary activator is, where they are localized. And you learn a couple of things from this. One of which is that this is where you think about the issues with the difference between mice and men, that the receptors are not distributed the same way in mice as they are in humans. Mm-hmm. And that may have implications for how drugs are developed and discovered and early findings worked out. The second thing you realize is that this receptor is fairly ubiquitous. It's on a lot of other cells, and so one needs to think about that as you do the clinical studies. We've been involved with a therapy called Vorapaxar. This was a drug first developed by Schering-Plough, now being developed by Merck. It's a very interesting drug that inhibits the thrombin response to platelet activation and subsequently aggregation. And we did a phase 2 trial led by Rick Becker, Dave Moliterno, and others that showed, I thought, two interesting things. One of which is that you can absolutely inhibit the thrombin's effect on the platelet. You can basically shut it off and get potent platelet inhibition, adding to both aspirin and ADP blockers. Secondly, there appeared in the phase 2 data, and this is definitely a hypothesis, to be a real sweet spot where you could get antiplatelet effect with efficacy, but not a lot of additional incremental bleeding. Mm-hmm. There appeared to be a sweet spot.
Mm-hmm. And again, just for the audience, this is an oral agent.
This is an oral agent. Yeah, Good pointing out of that. So we did, along with our colleagues at TIMI, 2 large-scale clinical trials. One called TRACER, which was an ACS population. Mm-hmm. Second called TRA2P, which is a secondary prevention population. And we've published the study design of both of these papers, both of these trials. This is a trial program that enrolled in the range of about 37,000 patients. So large populations of patients, the majority in the secondary prevention study, but a sizable number in the ACS setting. Mm-hmm. And this past January, we got a phone call from our independent DSMB that oversaw both trials. Mm-hmm. That said, in the ACS trial, you need to stop the follow-up in this trial. You've accrued enough endpoint information, and there's that ongoing trial could not be justified on some of the safety things we're seeing, largely bleeding.
Yeah.
As you know, in these discussions, you don't get a lot of information, but they told us we had had enough endpoint events. Mm-hmm. We brought the trial, to a close. We're going to present the trial later this year. We're closing out the data now. The second trial, TIMI 52 TRA2P, in that trial, they had 3 cohorts of patients. Patients who had a prior ACS event, mm-hmm. patients who had proven PAD, and patients who had had a prior cerebrovascular event. They specifically said, we'd like you to stop follow-up of the group of patients and discontinue study drug in those patients who had prior stroke, mm-hmm. but continue the others. So and they said it specifically because of increased risk of bleeding, and particularly increased risk of intracranial hemorrhage, but continue the other 2 cohorts. Mm-hmm. So that trial continues in its follow-up.
So this is a question that we know the answer to, but I'm going to ask you because I think it's important for the audience to know. Stroke, antiplatelet therapy, ischemic heart disease. Stroke appears to be a fundamentally different disease process, and perhaps it's time that we stop treating it as something that's similar to ischemic heart disease. Would you agree with that?
I think it's a great comment that for years a lot of us have said, look, atherosclerosis, it's a systemic disease.
Process, yeah.
Plaque rupture and thrombosis, it's a systemic problem. Mm-hmm. But I think we now have a lot of evidence that's accumulating. The effects of Clopidogrel seem to be different in the stroke population than the ACS population. Prasugrel had an issue in patients with prior stroke in terms of intracranial hemorrhage. On the anticoagulants, we've just talked about the Vorapaxar data. On the anticoagulant front, the APPRAISE-2 study, mm-hmm. Adding an anticoagulant to antiplatelet therapy appeared to be intolerable, including from a CNS perspective. I think we need to step back and say, maybe we ought to think of this differently. Maybe the doses are different. Maybe the targets are different. I don't think we know the answer to that.
And the fact that it's intracranial hemorrhage suggests that this is not a confounding effect by just sicker patients. I mean, they're not getting GI bleeds. It's specifically a neurological...
In the CVA population, it's intracranial.
Right.
There is, in all of these things, when you start combining them, there is more bleeding in general in that population. But I think what worries people is the... Because remember, the stroke patients on average are older than the coronary disease patients.
Yeah.
So it is something, I think you're absolutely right, that we need to work out. Vorapaxar is not the only thrombin receptor antagonist being developed. There is one that's also being developed by Eisai, and there's been several trials now presented, including this trial from Japan, that demonstrates a lot of the same findings, where you might be able to get a sweet spot of efficacy and safety. I don't know where this one is in clinical development, but the phase 2 data are starting to appear in the literature. The last topic I want to get to from the drug perspective, and I'll make a couple of general comments, is this concept of reversibility, another area where you've been involved. This is using technology that's actually come out of a Duke Basic Science lab, looking at aptamer technology to develop inhibitors of proteins, and then based on sort of classic Watson-Crick base pairing, to develop antidotes that can immediately reverse the effect of that inhibitor. And aptamers are a unique technology that might allow this to be pursued. And because of that, people have developed anticoagulants based on aptamer technology. And our group has published a series of papers, as you know, on factor IX inhibitor and its antidote. And we've seen that now progress up to phase 2 trials, where Tom Povsik and John Alexander recently presented some data at the ACC, saying that you can do this in a clinical setting and you can reverse it, and that reversal might matter. Well, the same laboratory is now beginning to look at antiplatelet agents, and they specifically have been looking at von Willebrand factor. As you know, one of the initial steps in adhesion is mediated through one of the glycoprotein receptors and von Willebrand factor and the disrupted endothelial surface. And so stay tuned for this one. This is very early, but I thought in the spirit of the future, we should talk about it. The final topic gets back to that last bullet point on the slide about personalization. We've talked a lot about, CYP2C19, and people say, well, it doesn't explain everything. Well, no kidding. It's because there's other mechanisms at play here, and here's just an example of something else appearing in the literature where this PON1 looks to be a major determinant, as stated in the title here, of clopidogrel efficacy. So it's not as simple as some would like us to believe, that if you just know your CYP2C19 status, you know everything about how that patient is going to respond to clopidogrel. I think that's a bit naive to think that there's one thing you can know and determine how patients are going to respond to a drug. Nice editorial accompanying that PON1 work by Eric Topol, really talking about how this is moving, this knowledge is moving the field forward. And I think that this is an editorial people worth taking a look at who are interested in the personalized approach. Finally, Sunil, as you know, we're very interested in understanding how these therapies, as they become not future but current, work their way into clinical practice. This is a large registry being run by Tracy Wang and Eric Peterson that's beginning to try to understand not the randomized trial findings, but how things work themselves out in clinical practice. So this is a project, Translate ACS, that's underway. So I'll close with the following. I think we've had a good discussion about thrombosis. I do think that platelets matter and that there's a lot of choices. I think we've got a lot of challenges ahead of us as we develop new agents to think about the kind of drugs we're developing, the patients that we're developing them in, the care strategies. We need more research on combination therapy. I think personalized choices will come, but I think we got some work to do.
It's fascinating how quickly this field has changed just over the last few years. I want to get your opinion or your perspective on the future of trials in this space. A lot of attention or a lot of interest in using the CYP2C19 status to determine entry into some of these trials. Some of those trials are ongoing right now. Obviously, with the Gravitas results, there's been a little less enthusiasm, sort of platelet function testing.
The trigger results.
Exactly, the trigger results. I mean, what do you think that we as trialists need to start doing? Is it more of a just a clinical risk assessment like we do every day in the clinic to try and get higher risk patients into these trials?
So it's a great comment. I think we're going to be going down two parallel pathways. The population-based approach to studying therapies has come under a lot of criticism that, you can't possibly believe that one size fits all. But from a public health perspective, with a disease that's as prevalent as coronary artery disease, I think that there's still value to the population health approach because you do a couple of things. You get the average effect across the population. You also quantify the risk across that population, which then becomes very informative for patients who are trying to weigh those two things in the context of what's important to them. I mean, some people don't want another heart attack. Other people say, I don't want any bleeding. And we as clinicians have to respect how people balance those things, but we need quantifiable information to present to them and say, this is your risk. This is what we think the average effect is. That's one approach. I think the population health approach should continue to go on. There's things we could do about that, but on the personalized approach, I think you're right. I think it's naive to think that there's one thing that's going to say, that's what predicts response. I think it's going to be an integrated response. And as informatics gets more sophisticated, why is it that we can't use phenotype, which is what you've described, risk assessment, plus some of the knowledge of that person's biology to try to understand who might benefit most from aspirin, who might benefit most from ADP, who might benefit both from the combination. And that personalized approach, I think, really needs some work.
So final comment, I think, is sort of bringing that kind of a concept into the clinical arena. We obviously have 2 thienopyridines currently available. We hope to have another antiplatelet agent available soon. Tell us a little bit about how are we here at Duke determining who gets clopidogrel, who gets prasugrel, for example?
Well, I think this is one where, you follow the evidence. And what my recommendation has been in our own practice and the way that I practice is that you should use clopidogrel in those settings for which it has a solid body of evidence. And you should use prasugrel in those situations where you think that more potent ADP blockade is better than less potent ADP blockade, and you have data to support that judgment. And so for me, high-risk ACS patients who are undergoing PCI, who do not fall into one of those high-risk bleeding categories, prasugrel is an outstanding choice. I think that prasugrel in the ST elevation MI setting, excellent data. We should be, we do use it here. We should use it, I think, more often. Where the data starts getting extrapolated is when you start doing things beyond that. It makes sense if your patient has had stent thrombosis on clopidogrel and you can't find an obvious cause like they didn't take their clopidogrel or you had a big edge dissection and improperly deployed stenting, that maybe prasugrel is a good choice. But I don't think we know that for sure. But that would be clinical judgment, and I think that would be reasonable. It's
probably important for each center to develop some kind of a set of standards so they can, the protocol then doesn't depend on who's on call.
Yeah, as you know, I'm a big believer in the notion that anybody who tells me I always do worries me because one size doesn't fit all. And there are clinical situations where you have to think about the patient, you have to think about their biology, you have to think about their angiogram, and you have to think about, in the cath lab, for example, what you're setting out to do. Is this multi-vessel extensive stenting that's going to take me an hour and a half? Or is this, a 20-minute procedure where I'm going to be in and out, and I might do things differently?
And their social support system nowadays.
Yeah, it's interesting, right? I mean, when you and I trained in interventional cardiology, that wasn't like one of the first questions we talked to patients about. Now I bet we both ask that question a lot.
So one of the most positive outcomes, I think, out of all of this confusion is the fact that we're forced to talk to our patients again, which is what we should have been doing all along.
We should have been doing all along.
That's right. Well, thank you very much, Bob. My guest faculty today has been Bob Harrington, my colleague here at Duke. Bob, thanks for joining us for an excellent presentation. We really appreciate your time.
Thanks for having me.
Until next time, then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.